Okay, this is Professor Tagwire here. It's Unit 7 of our course. And if you've done Unit 1 to 6, I trust that you did well in the quizzes and that you've learned one or two things with regards to snakebite and that you're a bit more confident now to chat with someone about snakebite. So just quickly, in this unit, we'll be looking at hospital management of snakebite and antivenoms. And at this point, maybe just to state that I might use antivenom and antivenin interchangeably in my slides. So by the end of this course, the participant should be able to discuss the hospital management of a snake bite patient. And nothing really in depth here, but really have an appreciation of what type of management would be expected to be given to a patient with a snake bite. And secondly, must be able to briefly describe how snake antivenom is produced. Thirdly, must be able to state the difference between monovalent and polyvalent antivenom or antivenom. I talked about monovalent antivenom in passing when we were talking about the boomslang envenomation. And fourthly, must be able to discuss the proper use of antivenom, including the circumstances under which it is required and the adverse effects associated with antivenoms. And then also must be able to list the snake species found in Zimbabwe, which the South African Institute of Medical Research polyvalent covers. And I mentioned the of uh, South African Institute of Medical Research polyvalent snake antivenom because it is the one that we would likely come across here in Zimbabwe. And I'll talk a little bit more about it. So the patient now comes to the hospital. They've been bitten by a snake. What is expected from the hospital staff? So the first thing that you want to do is to ensure that you've taken care of your ABCs to make sure that there's adequate airway, that there's breathing and circulation. Because sometimes you get a patient who comes in and is failing to breathe. And they're not failing to breathe because they've been bitten by a neurotoxic snake, but they're failing to breathe because they stepped on a snake which was non-venomous, which bit them, but as it bit them, they were chewing on a piece of meat, and some of the meat got stuck in the airway. And now they're having difficulty in breathing, and we are attributing it to a neurotoxic envenomation. So that's very, very important that the proper nursing management, the proper medical management be done at the hospital level. No shortcuts, even if it is poisoning or snake bite. And then it is quite usual for anti-tetanus toxoid to be given. Then the antivenom or antivenin polyvalent can be given if there is evidence of envenomation from one of the dangerous snakes which we talked about, the medically important venomous ones. So the antivenom that we have here in Zimbabwe, at least the one that comes from the South African Institute of Medical Research, covers for the black mamba, the green mamba, so these two we find them in Zimbabwe, covers for the snouted cobra, Anchiatus cobra as well. So snouted cobra was referred to as Egyptian cobra in the past, covers for the forest cobra, the Gabon adder, the Mozambique spitting cobra, the puff adder, and the wrinkles. And whilst we're still here, perhaps just a quick revision so that you can link this information and this knowledge that I'm just sharing with you to what you've been through in previous units. So this antivenom would cover for how many cytotoxic snakes that we find in Zimbabwe. So we've got the wrinkles, which spits as well, the puff adder 2, the Mozambique spitting cobra 3, and the Gabon adder 4. So 4 snakes which have got cytotoxic envenomation are covered by the South African Institute of Medical Research polyvalent snake antivenom. Then my next question is, which snake which causes quite significant cytotoxic envenomation I mentioned three which were important in terms of most snake bites being as a result of those three snake bites with cytotoxic envenomation. I mentioned a puff adder, I mentioned the Mozambique spitting cobra, and I mentioned a third one. What was that third one? Correct, lady with the pink top. It is the burrowing asp, or Bibron's burrowing asp. So you notice that Bibron's burrowing asp is not covered by the polyvalent. So if someone is bitten by Bibron's burrowing asp, do not give the polyvalent, especially if it is this particular one. And then of these ones, which are the neurotoxic ones that we have in Zimbabwe? Black mamba 1, green mamba 2, snouted cobra, Inquietus cobra 3, 4, forest cobra. But like we said, green mamba, forest cobra found largely in the Eastern Highlands, so bites extremely rare. But black mamba can occur in snouted cobra. So you'll notice that this polyvalent snake antivenom does not cover for snakes which have got hemorrhagic toxicity. And for those, if you recall, we talked about the antivenom, and we said that there was a monovalent antivenom which covers a boomslang, a monovalent antivenom which covers the boomslang. And you can actually dial a hotline for that antivenom to be flown from South Africa to wherever you are. Well, at least to Harare. Then you try to find means and ways of getting it there. Harare or Bulawayo, that's where you got the major airports in Victoria Falls. And there's no antivenom for the Savannah twig snake or the vine snake, if you recall. So we said there were two snakes which had hemorrhagic type of envenomation, the boomslang and the Savannah twig snake or the Savannah vine snake. And for the latter, there is no antivenom. And sometimes antibiotics are given, and I've put a question mark there because this is a subject of great debate. So before I move on to the next slide, if you see here for the antivenoms, it says it's refined equine serum globulins. So I just want to next slide where we talk about antivenom or antivenom. So antivenom is the only effective specific treatment or antidote for snakebite. And the way it is made, which we shall quickly go through, it is produced by hyper-immunizing large domestic animals. And the moment it says equine, that's referring to horses. And then the antibodies from those animals are got, the globulins, the purified, and then we've got two types of antivenoms. We've got the monovalent one or monospecific, and the example that we gave is which one? Yeah, well done. It is the boomslang. And then we've got polyvalent, which covers for numerous or a number of snake venoms. Polyvalent and monovalent. So just quickly, with regards to how antivenom is produced. So you get a snake or the snakes of interest, and the venom is collected. Once the venom is collected, it is injected into a large animal. So it's diluted concentrations of the venom, and then the horse or the animal will produce antibodies. It is bled, the blood is collected, and then plasma is collected from the blood. It is processed, antibodies are extracted, and then there's some processing that occurs, some purification, and then you get your antivenom, which can either be in lyophilized powder form, or it can be in a liquid form like we have used. That's simply the process. But because you're dealing with an animal, antibodies from an animal which is not a human being, it's possible that when somebody is injected by the antivenom, they can actually suffer from anaphylaxis, which we talked about earlier. And antivenom use, some things to remember with regards to using antivenoms. All right, here we go. So all commercial antivenoms carry a risk of potentially dangerous early anaphylactic reaction. And in the past, they used to talk about giving what is called a test dose, where you'd give a small amount of the antivenom and wait and see if there's going to be a reaction. But this procedure has been found to be a largely useless one because sometimes patients would not have an anaphylactic reaction, but when you give a larger dose, they then have the anaphylactic reaction. And also sometimes it's just wasting time for a patient who really needs the antivenom. But it's important to note, and like you saw in the slide that we had on the antivenom use, adrenaline is really good. We'll talk about it probably on a separate teaching, on a separate lecture on the what to do for snakebite and anaphylaxis. But adrenaline is really good, with or without hydrocortisone. Adrenaline is the key drug that you want to give there. And then also it's important to note that not all bites result in envenomation. We saw it earlier in our earlier units that there are some bites which are not non-venomous bites from non-venomous snakes. A python is non-venomous and doesn't require antivenom use. And there's also the concept of dry bites, which we talked about in one of our earlier lessons in one of the units. That sometimes a snake can bite you and decide not to inject any venom into you. And that's really important for you to keep in mind. Also, antivenom is very expensive and has got a limited shelf life. So those who are perhaps listening to this or subscribe to this course and in the supply chain management, your pharmacists largely, you want to make sure that the antivenom stocks that you have do not expire on you, and that you've got a good network to be able to exchange antivenoms, and perhaps distribute, and perhaps donate. And then there are also some species where there is no antivenom which is available. And I'll ask you an example of one. Yes, you're correct. For example, the Savannah twig snake. There's no antivenom. And management has to be supportive and symptomatic. And with the Savannah twig snake, it causes hemorrhagic envenomation. So supportive and symptomatic management or treatment. And then it's also important to know that some antivenoms are specific. Like which one? Like the one that we have over here. And that is the boomslang antivenom. So this antivenom would not work for a puff adder, neither would it work for a black mamba, because it is a specific. Okay. And then just moving on about antivenom, some bit of specifics. So the most effective route to use is the intravenous route. And the antivenom can be given at an injection rate of about 5 ml per minute, or diluted in isotonic fluid and infused over 30 minutes to 1 hour. And if IV is impossible, though not ideal, you can use intramuscular injection at different sites, like the anterior and lateral aspects of the thigh. And in children, it is possible to give it intraosseous, as to the bones. Okay. Now, this is a very important slide, because I've noted over my 15 plus years, almost 20 years now, of giving poisons information advice to healthcare practitioners, that there is a reluctance, especially in Zimbabwe, to give antivenom to patients. Whilst I did state earlier that we must be aware of the fact that anaphylaxis does and can occur, during some cases of snakebite, when you weigh out the risks and the benefits, it might be a good idea just to give the antivenom, especially if you know that this patient is going to die if antivenom is not given. Besides, if you are in a medical setting, anaphylaxis can be treated. So I hope that as healthcare practitioners are taking this course, that we shall see more deserving patients getting antivenom therapy. So these are the circumstances or the indications for antivenom use according to the WHO, as well as most snakebite experts. So you want to give antivenom in cases of neurotoxicity. So if someone is bitten by a very large or by a large elapid, so somebody is bitten by a black mamba, someone is bitten by a snouted cobra, and you are seeing evidence of neurotoxicity, and we saw the signs and symptoms tingling sensation in the tongue, metallic taste perhaps, facial palsy, ptosis, and other things like that. You want to give antivenom in such circumstances and situations. And number two, wherever there is spontaneous systemic bleeding, that should automatically make you start thinking about either a very large a puff adder or gaboon viper, or probably a boomslang. And if you are sure that it is a boomslang, you want to give the monovalent antivenom because it can be life-saving. And also, if blood is incoagulable, there's something called a 20-minute whole blood clotting test, which we will not talk about in this particular class, but is a method which is used to see if someone has been exposed to a snake which affects clotting. But just briefly, perhaps, so that you feel happy that you know something about it, a bit of blood is put into a small bottle, transparent one, and then it is left for about 20 minutes. And after 20 minutes, you'd expect blood to have coagulated and clotted. But if after 20 minutes you move the little bottle, and the blood is still not clotted or coagulated, then you suspect that someone has been bitten by a snake, which results in that. And like I said, two things would come to mind. One, the boomslang, or else some puff adder, a huge puff adder bite, or perhaps a huge a boomslang bite. Or in some cases, if there's cardiovascular abnormality, hypotension, shock, arrhythmia, abnormal electrocardiogram, and is associated with snakebite, then you know that there's some systemic envenomation. But the first three are the ones that we look out for largely in Zimbabwe. Then the other is focally envenoming species that cause local necrosis. Once you get extensive swelling involving more than a half of the bitten limb, you want to give an antivenom. And there is evidence from anecdotal reports, from clinical reports of puff adder bites which respond to antivenom even a day or 2 or 3 after someone has been bitten by a snake. And somebody's limb can actually be saved as a result of that. I mean, as a conservative, I would probably say a day after for a puff adder bite, if the swelling to be going down, a day after, 1.5 days after, you can still give antivenom. And then also, if you've got rapidly progressive swelling, and you can tell this is rapidly progressive swelling, you want to give an antivenom. As well as bites to the fingers and the toes. And the reason why is because when they swell up quickly, and it might be possible that the person might lose their limb because of extensive swelling, which then occludes circulation of blood to that particular area. And once I hope I have some, I hope I don't forget about it. But whilst I'm still talking about antivenom, it's extremely important for you to know that snakes don't choose the amount of venom to inject to a victim or a patient based on the age of the patient. So the amount of antivenom that you'd give to an adult is the same quantity that you would actually give also to a child. And with these neurotoxic bites, you'd find that you actually need significant amounts. Like, for instance, the mamba bite, you might need probably up to 80 mils of antivenom injected into the patient. So just quickly, with regards to adverse effects from antivenom, you can get early reactions which occur between 3 minutes to an hour after a starting IV administration, and there is cough, tachycardia, itching, especially in the scalp, urticaria or fever, vomiting, headache. And more than 5% may develop systemic anaphylaxis, approximately 5% or even more, depending on the type of antivenom which is used. So it's actually extremely important for you to buy antivenom from proper suppliers who've been at the business for a while, because some of the contaminants are the ones which lead to some of these reactions that we see. So anaphylaxis can be characterized by hypotension, bronchospasms, angioedema. And you can also get pyrogenic reactions which occur an hour or 2 afterwards. and then late reactions which can occur 4 days and up to 24 days later. So this is your serum sickness type of reactions with itching, urticaria, fever, arthralgia, and related symptoms. So I hope you got something with regards to antivenoms. I mean, there's a lot to talk about these antivenoms, but the plan is to try and keep the videos as short as possible, about 20 minutes, 22 minutes if I continue talking for too long. So just before I go, just one other important thing which I wanted to talk about with regards to antivenom. So it's important for you to get antivenom from a company that uses snakes which are found in the region where the antivenom comes from. Because you see, we said earlier that the venom composition was proteinaceous, they're like proteins. And for those who did biochemistry, you'd know that changing one base can actually change the function of an enzyme completely, or of a proteinaceous substance. So it's possible that if a snake is bred in India or in China and it's a puff adder, this type of symptomatology that you get from the venom might not be the same as the one that you get for a snake from Southern Africa. And that's the reason why I was referring specifically to the South African Institute of Medical Research Antivenom, because the venoms that they use are taken from within the same geographical region, so to speak, in quotes, as we have here in Zimbabwe. So I would tend to trust that antivenom more than I would trust from someone who's breeding some snakes in another environmental and geographical area elsewhere out of the continent. Okay, I've talked too much for the day. I had lots to say, but well, there's always next time. This is Professor Tagwire, and I say, well, see you when we meet for the Unit 8, the final one. Enjoy your quiz, do well, pass. It's Professor Tagwire. I'm saying I'm out. I'll see